whether it's a PED present or PED absent, large or small PED. However, if I'm not sure whether or not the PED is perhaps very tense and I'm afraid of a rip, sometimes I will give an anti-VEGF first. You can start with 2-3 anti-VEGF, try and bring the height of the PED down, decongest, and then consider later what you want to do with the models.
We treat the PED without any subretinal fluid?
Yes, you can treat PED without subretinal fluid, especially if they are symptomatic and especially if they are very large. By very large, we mean a height of say more than 300 microns. Again, that's arbitrary, we don't have a fixed cutoff. But anything with quite significant elevation of LPE, I think it has to be controlled, it has to be treated. Another observation is that in PCV, the resolution of PED is fantastic. Very different from pure serous PED. You don't know what to do with them, right? You inject, you do this, you do that, it's still the same. But in PCV, the PED disappears. And that's the same with RAP. When we see RAP and a PED, if you treat the RAP, whether with usually with anti-VEGF, they are quite sensitive to it. And the PED will flatten. Sometimes with one injection, the large PED can disappear. So I find that the treatment of PED in the context of PCV is actually quite satisfying, as opposed to without CNV or pure serous PED. That is really still a major problem that we face. So maybe Professor Takahashi later, when he talks about long-term management of DME, that may be one area you can also ask him for his opinion. Let's move on now to DME. Just now you had some thoughts from Professor Bressler, where he updated you on DME and PDR, correct? So go back to DME. Now we have a situation where we think that the DME is not responding to anti-VEGF. Just now you heard from Professor Bressler. In the first year, anti-VEGF treatment, whatever agent you use, has to be quite intensive. And by intensive, we mean 8 to 9 injections. That's very clear. So if you tell patients that you're going to give 1 injection and wait, 2 injections and wait, I don't think that is the right message, right? I think when you heard from Professor Neil Bressler just now, the reality is you have to probably give 6 monthly injections, almost. So unfortunately, that's the situation. Why? Because the level of VEGF in a diabetic is actually higher than in neovascular AMD. And it takes a longer time to build up to reach that level. So for you to reset and slowly to dial everything down needs more injections. That's my understanding of it. Maybe it's too simplistic. But the problem with diabetes is it's not so clear-cut, because sometimes there are pathways that are not driven by VEGF alone. And that's where we run into problems. So we know that the DME has evolved. We didn't have anything before. We had focal laser, we had grid laser. All this is from ETDRS, right? How many of you still do ETDRS at least 1 case a week? ETDRS type focal grid laser. Very good. Yeah. So I think most of us still do ETDRS grid laser, focal grid laser. Yeah? But less and less, correct? Less and less. So you see here the evolution has really changed. Initially laser photocoagulation, and then we had steroids. After that, and the anti-VEGF agents. Actually, before this, we had pegaptinib. I don't know how many of you remember Manfusion. Pegaptinib is actually quite a good drug. It is anti-VEGF 165, isoform 165. Okay? Maybe not as complete block like bevacizumab, but actually very good safety profile. But somehow, you know, the company lost its way, and basically it's out now. Right? It's no longer available. Another concept that has changed over the years, besides the treatment and modalities available, is how we assess DME. In the past, it was clinically significant macular edema, which is a clinical diagnosis, usually on slit lamp biomicroscopy. Okay. Things like retinal thickening within 500 microns, Anything more than one disc diameter, any part of which is within one disc diameter of the fovea. Right? All these definitions we don't use anymore because we now have OCT. And with the OCT, the terminology is center involved or not center involved. Actually very easy. Right? Center involved just means central subfield thickening out of the 3 rings, the innermost ring, which is the central, how many mm? 1 mm. First ring, 1 mm, second ring, 3 mm, third ring, 6 mm. And now we are going to 12 mm. Right? We now have OCT systems further and further out. So center involved versus non-center involved, very easy to understand now. Patients can understand immediately. The other concept is traction. We won't be talking about traction this afternoon, but that's important. Because if your pathology of macular thickening is mechanical, why are you giving injection? Injection is not going to solve anything. So don't forget that posterior hyaloid thickening, vitreomacular traction is the easiest thing for you to exclude. Straight off, you examine the eye, you do an OCT, and you know straight off, this is under traction. Maybe we should be talking about surgical intervention. There have been many sort of ad boards and so on, but I like this one, the expert panel chaired by Francesco Bandello, who by the way is one of the scientific chairmen of ISASO. So he is very intrinsically linked with our ISASO curriculum. And he chaired this program where if it's non-center involved, they recommend ETDRS treatment, right? If it's center involved, but the vision is still normal, by normal we mean 6, 6, 6, 12, up to 6, 12, you can still treat with laser regulation. And then if there's visual impairment, symptomatic, we will treat with anti-VEGF. Please remember at that time, we now have equivalent. What is in dispute is this part. So some of the newer protocols from DRCRNet will answer the question, what do we do when the vision is normal or near normal? At the moment, we still don't have evidence to guide us. One way of looking at it is, why do I want to wait for my vision to drop before I do something? Right? So patients will say, my vision is good now, and I want it to be like that. Why do you want to wait until 6/12 or worse before I get a treatment? Why do you treat me now? On the other hand, other patients will say, my vision is normal now. Why do I need treatment? So you talk to your patient. It also depends on their requirements, obviously. Right? A patient who is a pilot perhaps cannot afford to have 6/12 vision. So this no vision loss is subjective and it is circumstantial, depending on the situation. All right? Up to you how you have your discussion with the patient. This is an example of non-center involved. Central subfield not thickened, you see that the area of thickening is outside. ETDRS is very good for this type of patients. Usually we do a modified grid, overline the area of thickening, and usually that should settle. If the fovea becomes subsequently involved, let's say after laser, the fovea becomes thickened, you can still add an anti-VEGF. Okay. So the ETDRS, as you know, was very effective in preventing visual loss. Right? Pretty good, preventing visual loss. And we know it works. We have thousands of patients who probably have their eyes still retained. They might have lost their limbs, they might have lost their kidneys, they might have gone for a stent in their heart, but their eyes are still fine. Right? But the problem is improvement in vision. Right? Now our bar is set very high. We all want to experience improvement in vision. And unfortunately, that's not so. Most of the cases treated with focal laser maintain vision, maybe lose a little bit of vision, but less loss than if you didn't treat. Is that satisfactory to you now? Let's say if you are diabetic, I tell you, I'm going to chop off one finger to save your hand. Are you happy with that? No, I want another hand. Right? So, I think with anti-VEGF, we can achieve improvements in vision which we had never seen before in DME. And that was what's so wonderful about anti-VEGF. In fact, I think if you look at some of the commentaries, what the biggest, the most revolutionary changes in medicine. Anti-VEGF therapy for eye diseases is one of them. I would say top 10. And we are lucky to be in this era. The next question was, if I have the two, we know anti-VEGF is good, and we knew that laser was pretty good in terms of long-term stability, prevention of vision loss. What if we combine the two, right? Two doesn't mean better than one, unfortunately. If you look at Restore, and we also did a similar study called Review in Asia, we found no advantage of adding laser immediately to anti-VEGF. It goes against our intuition, right? We think that maybe it would reduce injections, maybe you would have longer stability of vision, you don't need to give so many injections. But unfortunately, combination in DME has never been proven to be superior to anti-VEGF monotherapy. So as of today, we don't recommend immediate laser photocoagulation. If you look long term, the patients who were treated with laser alone did very badly, right? I mean, compared to anti-VEGF treatment. When you switch them over, and now you start giving them ranibizumab, their vision starts to improve. But it doesn't quite catch up. And look at the end of the study, full analysis, the group who had combination therapy actually lost a little bit of vision. And then they became about the same as those who did not receive anti-VEGF from the outset. So the moral of the story is that if you are going to add laser, you add later. Adding it in the beginning doesn't help. And still, you should not use focal grid laser if the center is involved. Right? So I think that's clear, right? First principle, anti-VEGF first line, when there is center involvement. If there is no center involvement, go ahead and do ATDRS focal laser. These were the pivotal studies. I think I don't need to go through the details. Rise and Ride, Vivid and Vista. I hope all these are ingrained in your vocabulary. Yeah. So Rise and Ride was for ranibizumab. You see the great change which continue to increase. Actually, beyond the 3 months, you see that after the loading dose, it is not a straight line. The vision continues to improve. 6 months, 9 months, sometimes 12 months. So it means that diabetic macular edema, despite resolution, so let's say OCT is flat, dry, 3 months, the vision continues to improve. It doesn't, stabilize. This is not so in AMD. In AMD, after 3 months, more or less, the vision flat. And then your task is to maintain. Okay? If you look beyond 2 years into 3 years, and then you switch, those who were treated with laser monotherapy, they did not improve. So sometimes if you wait too long, by the time you wait for 2 years, just laser alone, probably structural damage will have occurred. These are all treatment naive, by the way. So you don't actually have forever. You do have a bit of time. But by 2 years, if you have not done something to dry the center, you might have lost the opportunity for removal. So let's go back to this question. What is response? Because if we don't understand response, then we won't be able to define non-response. Right? So bear with me, this is a little bit technical. Definition of response can be based on anatomy, which is morphological, right? OCT changes. Resolution of intraretinal fluid. Sometimes subretinal fluid. Occasionally you can get subretinal fluid in diabetes, but majority intraretinal fluid. Or it could be visual outcome. The visual outcome could be visual acuity. Some clinical services, health services use vision. Others use patient outcome, right? I want to get treated today, I don't want to get treated today. Or it could be a population-based outcome. All these are sort of theoretical, what measures we use. But in general, if I were to ask you, what is a good response? Well, one is simple, 6/12, 73 letters, driving vision. I'm able to continue in my work, I can still live independently. That's one definition. Another definition is a gain in 5 or more letters. But remember, there is a ceiling effect, right? If you start off with 71 letters, how are you going to gain 5 letters? Very difficult. But if I start off with 40 letters, sure, I can gain 10 letters. So remember the ceiling effect. And there is this thing called clinically meaningful change. Most times we say 2 lines or more on standard. That's significant. It's quite a lot. Massive change, if you want to say. So clinically meaningful is also important. Let's say we had a trial with 2 agents. And then the difference in gain in vision was 2 letters between agent A and agent B. Statistically significant, 2 letters. But is it meaningful? Maybe not. Right? That means would the patient be able to tell from one treatment to the other? Maybe. Right? So always bear in mind that sometimes what we know statistically may not have any meaningful impact on the patient. Then on the flip side, we can look at those who failed therapy. That means despite your treatment, they go blind. Severe visual impairment, or 6/60 or less. All right? So these are just some examples. You can think of more examples of a typical response. But what would be the sort of response that you want to envision? One is do not lose vision. Right? A treatment which is effective must not result in a loss of vision. An anti-VEGF satisfies that criteria. 1% or less lose vision. Number 2, gain as much as you can. So if your baseline is low, you gain a lot. Baseline is high, you gain less. You accept that. Right? And then finally, stability. You don't want fluctuation. One day, 6/6. Next month, 6/60. And then 6/60 again. That is really no good, because if you follow that, you track the macular OCT, for example, you don't want to see this seesaw pattern. The seesaw pattern is not good for the longevity and the health of the RPE. Okay, so stability of vision is also important in the long run. Now, you've heard a lot about DRCR-net, and he's the expert. Okay, so I'm just going to draw some lessons from DRCR-net. The first is the definition of response in DRCR-net is reasonable to me and very measurable. Improvement in more than 5 letters. For us, it's 1 Snellen line improvement. Okay, good. 2 Snellen line, even better. 3 lines, excellent, right? 3 lines is 15 letters or more. So if you can improve at least 5 letters on 1 line, and you have a decrease, this is morphological, of at least 10% since the last injection. They define this as a response. So if you were to look at this, 2 criteria, this is or, by the way, not and. The majority of patients who are started on ranibizumab or aflibercept will satisfy this criteria. Okay? Therefore, the drug is actually very successful. Statistically, what is it? 94, 95% maybe, who would satisfy a response criteria. Then, of course, the anatomical response. We have VA response and we have anatomical response. These are just terms to help you understand better that the whole thing cannot be lumped into one big basket. Some are persistent fluid, others are recurrent fluid. Why does it help to distinguish the two? Because when you choose agents and you decide to add something, let's say you started with anti-VEGF-A, then you're deciding whether to add laser. You have to decide, is this persistence or is it recurrence? And then you're deciding between changing from agent A to agent B. You have to also decide what was the response to agent A. You have to be clear in your mind why you're going to change, why you're going to switch. The keyword, buzzword is switching. Right? So be very careful when you want to switch. I have some patients, after 1 injection, no response. That means less than 5-letter improvement, less than 10% reduction. Straight away the physician wants to switch. Is that fair to the drug? And is that fair to the condition? Probably not, because we know it's not going to change so quickly. I've listed a few factors which influence outcome. I think they're quite logical, probably self-explanatory. Baseline VA obviously has a part to play, right? I mentioned the ceiling effect. Your retreatment criteria is also important. If you have very relaxed treatment criteria, don't ask the patient to come back often, don't assess it, you don't have any strict criteria for retreatment, of course, you will end up with poorer outcomes because of long-term photoreceptor damage. And then finally, real-life patient and other factors. So I've just listed a few good prognostic factors and bad prognostic factors. So that when you start, you know already, how is this patient likely to do. Higher baseline VA, counterintuitive, right? You would think that if you have more gains, maybe they will do better. No. Higher baseline VA means they still got photoreceptor integrity. Disease has not been so chronic. Maybe less ischemic. All these factors are in favor of a good outcome. It doesn't mean fewer treatments, by the way. It just means your final visual acuity is probably going to be better. Male, that one I don't know why. Younger patients, makes sense. Shorter duration of DME also makes sense. Subretinal fluid, that's counterintuitive. I thought that subretinal fluid would be a poor prognostic factor because we tend to see it very chronic DME and more ischemic DME. But in this study from Morpheus, they found that SRF, subretinal fluid, seemed to have a better prognosis. And hard exudate is also counterintuitive. In the days of laser, if we see a lot of hard exudates, we were very afraid to apply laser, right? After you start applying laser, they become a plug. They gravitate towards the fovea and end up with a very solid plug, and they lose vision as a result. Those were in the days of laser. I hope some of you still remember it. But with anti-VEGF, that seems to have gone. Those days, we don't see so much. Because when you stop permeability, you stop transudation, and you also stop exudation. So in a sense, I think the protein leak stops. Whereas with laser, maybe the laser process itself induces inflammation. That inflammation worsens exudation of protein, and you get more deposits of protein, maybe. It used to be thought that if you see a lot of protein, you give steroid instead. Right? That was before anti-VEGF. We used to give triamcinolone rather than laser, or maybe we do a combination, because the steroids will dial down the degree of inflammation and hopefully reduce exudation, not just transudation. The other factors are still uncertain: choroidal thickness, ellipsoid layer, OS length. But these are the poor prognostic factors. I just want to highlight a few. Drill, D-R-I-L. Anyone knows what that is? Fantastic. Great audience. Drill. This organization of retinal inner layers. I mean, all these acronyms are just, someone cooked it up. In this case, Jennifer's son cooked it up, and it's been attributed. Jennifer's group. This is from Justin, Boston. Is the horizontal extent in microns with disruption to the ganglion cell, inner plexiform layer, inner nuclear layer, outer plexiform layer. Right? Not the ellipsoid. It is the inner retina. That's why it's DRIL. And it was shown in her study to be correlated with final visual acuity. So this is an example. These three layers, GCL, IPL, INL, OPL, and ONL. When there's no drill, visual acuity was better despite presence of fluid. And when there was significant drill, in this case 570 microns, despite resolution of fluid, the prognosis was worse. The final VA was worse. So in conclusion, they had said that the disorganization of the retinal layers within the 1 and M area is directly correlated with final visual acuity and predicts future change in vision. Are you all looking for drill before you start treatment? Maybe you should. Because when you warn patients that you've started out already with a bad hand, then likely your vision is not going to improve. Otherwise, the patient will say, why is my vision still like that despite resolution edema? Because when you have significant drill, your aim is to prevent further drill, further loss of vision. perhaps not significantly improvement in vision. So that prognostic expectation helps you in your relationship with your vision. Right? We talked about the ceiling effect, so I won't belabor the point. Right? The higher the starting PA, the less the gain. That's normal. So tell patients, your vision is very good, so you're not going to have a wow effect. But your aim is to maintain your current vision, so you can read, you can drive as well. I think you'll understand that. In general, there is a linear correlation. Right? So the thinner the OCT, in inverted commas thinner meaning less fluid or no fluid, the better the vision. Right? The thicker the macula, or the more fluid there is, the worse the visual acuity. But it's not always the case, as I said. Yesterday we talked about atrophy. Atrophy is less of a problem in DME than AMD, right? AMD, the process affects the RPE and photoreceptor complex very early in the disease. So geographic atrophy is a real problem and a consequence of AMD. But in DME, most of the disease is inner retina because it is a retinal vascular problem, right? Your endothelial capillaries are leaking. So it takes time for that process to trickle down into the outer retina before you end up with atrophy. So let's go back to this definition of non-responder. Unfortunately, there is no universal agreement on non-response. I will say one thing and Professor Bressler will have another definition. But you can use some of these as guidelines. They've been used before in studies. A drop in 10 letters from baseline. VA consistently less than 37, that is visually blind. And central subfield thickness of persistently more than 400 microns. Interestingly, in the UK, the NICE guidelines and then NICE uses 400 microns as a definite indicator for anti-VEGF because those are associated with much worse prognosis. The protocol I think, did Professor Bressler go through protocol I and protocol T? So I don't need to go through the design, right? Basically, they had patients who did not respond uniformly. That's normal, right? You'll see that 50% had early and consistent response. You treat, macula dries very rapidly, stays dry. And then they had the other extreme, 26% did not show any response over 52 weeks. What they term non-responder. Right? So remember that, 26% in protocol I. And then there were these two groups in between. Early but inconsistent. That means in 3 months or so, within 3 to 6 months, fluid had gone away, but it kept coming back. The other group was slow and variable. You don't see the response until later, maybe in the second half of the year. So obviously there is quite a wide spread of response patterns. How are we going to know whether the patient will be first group or in the last group? We won't know. So I tell patients that there is proportionately 50% will be good, early and consistent, 25% not so good, no response, and then somewhere in between. So that it sets out some expectations for them. This is an example of early and consistent. This 32-year-old, 6/12 vision in the left, 6/5 in the right. The main problem here is in the left. You can see macular edema, which is center involved. The patient is then given ranibizumab, 5 injections, and the macula dries up consistently. Very early response within 5 injections is dry. After 7 injections, week 60, so that's quite good, right? 60 is 5 years. He's only had 2 more injections, and his visual acuity is 660. So this is one example of early consistent response. Early inconsistent response, as shown in this 45-year-old physiotherapist. You find that 624 vision, 618 has had some PRP for severe non-proliferative disease. In the right eye, pre-ranibizumab, 6/24 vision, quite severe macular edema, center involved again. February 2011, dry. March, dry. So early response. Vision improved. Very good. However, it starts to come back at 6 months. doesn't hold for anything beyond a year. 7 to 12 months, dry. Recurs 13 months. So ranibizumab needs to be given on and on. You can't stop therapy anymore. Late responder, group 3. Right? Don't see any response in the first 6 months. This is a patient with quite long-standing history, very severe macular edema as well as subretinal fluid. Visual acuity is 624. Look at that central subfield, 718. And as you give, there is still no response. This is January, right eye, left eye. After 1, hardly any reduction. There is a response, but hardly any reduction. After 4 injections, the right eye still persistent edema. Left eye, not bad, after injections. 4 weeks later, the right eye comes back again, 6 doses given. So it's a late responder in the right eye. And this is also not uncommon. We see this in 10 to 15% of patients. I'm sure in your own cohort you will have roughly that group. In all 12 injections, vision still good, but his central subfield thickness is still 420. Not ideal. 17th of February, bilateral injection still ongoing, 3 years on. He has had PRP, vision is stable, 15 injections in the right, 8 in the left. The left was better as you could tell. But really, this is a patient you cannot let go. You have to see him 2 to 3 monthly. Otherwise, you would have doubled the follow-up, right? If you look at protocol I and protocol T, from 1 month to 2 months, 2 months to 4 months, 4 months to 8 months, you can double the follow-up. But in these patients, you can't. And then a true non-responder, which is actually quite rare. 48-year-old male, significant macular edema in the left eye, 6/12 vision, 1 injection, 2 injections, doesn't seem to have any effect whatsoever. 3 and 4 and 6, then we add laser according to protocol I. No response. So 6 months, central subfield is still 540 microns. And maybe it's because it's related to renal function, we're not sure. But his visual acuity all this time, despite that amount of fluid, is maintained. What would happen if we don't treat? Let's say we did not give him any anti-VEGF. Likely his vision will slowly get worse. So while you're maintaining vision, you may not always succeed in eliminating macular edema. In other studies, we've shown that 40% of anti-VEGF treated DME have persistence of fluid. So this is a typical example. 8 injections of fluid has increased over 8 months, over 1 year. The question most people would ask is, would you have changed agents somewhere earlier than that? And if you change, what do you change to? And would you switch pharmacological agent altogether? Rather than anti-VEGF, would you go to steroids? So we'll try and answer those questions in the following slides. The DRCR-NET protocol T showed that if you use Avastin, 54% at baseline vision, 54% at OCT CST greater than 250 microns. 250 was considered gold standard, perfectly dry macula. Meaning over 50% of patients continue to have persistent macular edema. With aflibercept only 25%, ranibizumab about 33%. So 20 to 50%, 25 to 50% have persistent edema despite following protocol T. Protocol T was very stringent. They will get first 6 injections likely, and they will end up 8-9 injections in the first year. 1/3 of study eyes in protocol I showed edema at every visit in the first year. This is the patients who are either non-responder or very late response, not the early consistent ones. And the eyes who had this persistence of edema obviously had less vision gain. So there is a reason why we try and dry the macula as quickly as possible. Yes, anti-VEGF can maintain the vision, but if you stop, let's say in the third year you stop, or patient absconds, or disappears due to some intercurrent illness, I think the visual acuity is really lost. So the question is why? Obviously, some are due to tachyphylaxis. So you give a lot of injections, they develop antibodies, right? And then they develop a kind of resistance to the anti-VEGF agent that you're using. So if you suspect that, you have to stop therapy, switch agents, and hopefully you get a response rate. Sometimes it is due to inadequate treatment. What I mean is that sometimes we give 3 loading doses and then stop. I think that's quite common. How many of you tell patients, I'm going to give you 6 monthly injections for your DME in the first year? Anybody? 6. Very good, 6. Maybe some of you should consider telling patients it is likely you will require 6 initial injections, not 3. Because after 3 injections, it's very hard to be sure that it's not a delayed response. Okay. So I would urge you to think about telling patients, let's go to 6 injections and maybe 2 more towards the second half of the year. Because if you go back to the DRCR-net principles, before 6 months, you treat every month unless the visual acuity is perfect, 20/20, or if the CST is normal, which is less than 250 microns. Okay. That means you keep going until perfect. After 6 months, if you don't have any further improvement, then you tolerate it. You can defer the injection and add laser. So this is actually been covered, correct? This is just to reiterate. And after 12 months, if you still don't get any further improvement and there's no worsening, you can defer and extend. Different from treat and extend, okay? Treat and extend means every visit I treat you and then I extend. This one, we defer. If you come at 2 months, it's the same. I see you in 4 months, don't treat. At 4 months, if you're still the same, visual acuity the same, CST no change, I defer to 8 months, don't treat. Which is quite good, right? It's good for patient. After you defer injections, if at any time the acuity drops or the OCT worsens, of course, you resume your injection. Is that quite clear? I took a while to get used to this protocol, but it's actually quite intuitive. Okay? So let's go a little bit into details why we've drawn some of the lessons from DRCR-net. This is protocol I won't go through it again. And you know that if you just use laser, visual acuity gain was very low. When you give ranibizumab, immediately the vision improves, it continues to improve. You see it doesn't go at a straight line, it goes up at 1 year. And the group that had deferred laser after 6 months did better than those who had immediate laser. Why do you think that's so? Why do you think that immediate laser ended up with poorer result? We don't know the real reason actually. We have some ideas. Anyone? Is it the laser causing some damage? Inflammation? Yeah, possibly. I think it's because when the macula is thick, you use more laser energy to achieve a threshold burn. Because you want to see it. If you use subthreshold, maybe it would be different, I don't know. You know? But because you want to see a burn, you have to hit it harder and harder and harder and harder because the fluid is still there, the macula is still there. The landmarks are obscure. And sometimes you end up causing more damage than good. That's my theory. Then triamcinolone does well initially but comes down after that because we all know it's basically cataract related. And then when you do cataract surgery, what happens? You get worsening of the DME and they don't pick up, you know. So after the cataract surgery, they don't do well. So it's good for those who are already pseudophakic and you don't have to do cataract surgery for them. That's reasonable. But if they are faking, think carefully about triamcinolone. This is out to 5 years visual acuity is still maintained in the deferred laser group, slightly better than immediate laser group. Same with improvement and worsening. So if you look at the change in subfield thickness, look at the triamcinolone bounce. And that's because they were given at 6-monthly intervals, and the effect of triamcinolone does not last 6 months. By 3 months, fluid comes back. You give injection again, it comes down again. I think we've talked about number of injections already. The number of injections in the first year is very high. But fortunately, if you use the same protocol, only 2 or 3 injections are required in the subsequent years. Another benefit of anti-VEGF is improvement in diabetic retinopathy level or scale. Don't forget that you are dealing not only with DME, but also for the risk of proliferation. Sometimes we forget. So when we treat with steroids, well and good, maybe you end up with better diabetic DME control, but not diabetic retinopathy. And you may still go blind from that. The last part of my talk is really to look at non-VEGF mediated pathways. Right? We know that it can be vascular, inflammatory, and neuronal. Of course, the most important factor is still VEGF, consistently. And that's why anti-VEGF is the first line. But we know that inflammation plays a big part, not just in diabetic retinopathy, but in diabetes as a whole. Right? Many examples of how hyperglycemia upregulates inflammatory cytokines, not only in the eye, but throughout the body. More leakage is due to higher levels of these cytokines. Direct correlation. And all these inflammatory biomarkers are higher the worse the DME is, so you can correlate it with the macular thickness. Pro-inflammatory cytokines will cause all these cellular changes, such as parasite loss, endothelial cell tight junction degradation. And that's how they end up with very persistent, very chronic edema. You heard about microglia and macroglia. Okay? The microglia are sculptors, gardeners, surgeons, sanitation crew, whatever you want to call it, but they are in charge of pruning. You know what's pruning, right? You've got a big tree, you have to cut old branches, dead leaves, and so on. Very important in inflammatory disease and of course in vascular disease. The role of microglial cells is only now being understood. And how do we know that microglia are involved? Because they're activated by hyperglycemia. So there's a real reason why we see all these activated microglia within inner retinal cells, layers of the retina. This is a diabetic retinopathy with upregulation of microglia shown by the marker IBA1. And clinically on the spectral domain OCT, you can see these hyper-reflective dots. Next time, go back and look at your patients with CRVO, with DME, with radiation retinopathy. They all have increase in hyper-reflective spots or dots. And if you can count them, you've got so much time, you can sit down and count them. You can actually correlate it with the central retinal thickness. Right? No need to count. I'll tell you that there is a direct correlation. This is an example. All these little bright specks in the middle and inner layers of the retina. You see all these? These are hyperreflective spots. And as you treat with whatever, anti-VEGF also will reduce the hyperreflective dots. If you use steroids, these hyperreflective dots will also reduce and finally resolve. But we're not only talking about microglia, there are macroglia involved. In the retina, of course, is the Mueller cells. Mueller cells is really an interesting cellular structure because it spans the entire expanse of the retina. So it actually is the neighbor to everybody, right? He's like the busybody. And if you make him unhappy, he's going to make your life very, very unpleasant. So how can we suppress inflammation? I mean, steroids obviously are the most obvious target, right? We've got dexamethasone, which suppresses all these, and it also has a mild anti-VEGF property. So steroids can help in proliferation, but not as much as the anti-VEGF. Triamcinolone produce significantly reduced cytokines compared to bevacizumab. It's quite obvious, right? Because it's anti-inflammatory. And there are relative potencies of steroids. So not all steroids are equal. You have dexamethasone, which is higher than the rest, and fluocinolone. And it's no wonder that the two drugs that have been approved for DME treatment are actually dexamethasone and fluocinolone, because they are the most potent steroids. The MEAD study was the pivotal study for DEX implant, Ozurdex training. Okay. It was quite a large study, 1,000 patients, 3 groups, sham, a lower dose of DEX, and the now current one, what we are using is 700 microns. These patients were treated, evaluated for retreatment every 3 months, but we were only allowed to inject them every 6 months. The initial idea was that these implants could last 6 months. The whole study was for 3 years. This is the age duration, quite well balanced. The DME characteristics, you'll see that they were quite significantly thicker. All of them were over 400 microns central subfield. And a significant proportion of them have had laser, you see, 70%. This is a quite old study because at the time, we didn't have anti-VEGF that much. So a lot of patients had already received laser. This is the study eye characteristics. Phakic eyes, majority, over 70%. And of course, the number of treatments is determined by the treatment protocol. So you can only treat every 6 months. The maximum would have been 7 treatments. But we actually now know that 6 months is too optimistic. With the DEX implant, fluid starts to come back and visual acuity starts to drop after the 3rd month. At most, it lasts 4 months consistently. But if you wait for 6 months, the vision would have started to drop. Maybe not the baseline, but it would have started to drop. So now the current usage of DEX is every 3 to 4 months. Every 3 to 4 months. If the patient was already pseudophakic, remember the effect of cataract surgery with triamcinolone. So we wanted to look at pseudophakic patients. They did actually better. So one conclusion of this is that if you've got pseudophakic patient, I would be more willing to use steroid than if they were faking, because I would not have the risk of post-cataract surgery complications on the retinal. This is just to show you that the visual acuity improvements were good, but not as spectacular as anti-VEGF. Central subfield thickness, you see a significant reduction in the 2 treated arms. Of course, this is very important. What were the adverse events? We were afraid about endophthalmitis, but that was unfounded. We thought if you suppress inflammation, you also suppress immunity. We didn't see hypotony, so the wound doesn't leak. Right? That's good. We didn't have retinal detachment. That's pretty good. But we did have cataract and glaucoma. So cataract, of course, 67% in the DEX 700. And the rate of cataract surgery is 60%. So you just have to bear that in mind. If you're not prepared to do cataract surgery, don't put in a DEX implant. Actually, it's the same with triamcinolone, right? Triamcinolone is similar to this, 60%. And in terms of effect on IOP, 30% had a greater 10 or more mmHg rise from baseline. That's a lot. So I think you cannot run away with these 2 adverse effects: pressure and cataract. You have to be prepared to manage them and also to counsel patients about this. Fortunately, most of them could be controlled with drops, so very few procedures were required. In the meta-analysis of Ozurdex for non-responder to anti-VEGF, you see that the majority of patients did not improve their vision a lot. They could dry the retina. But functionally, you don't get a significant improvement in vision, mainly because perhaps photoreceptor damage had already occurred. Maybe you waited too long, to dry the retina. So there are obviously some benefits, but consider that the risks are also significant. Cataract, 60%. IOP rise, about a third of patients. There are other slow release devices. This is Orgedex, so for those of you who have not seen it, it looks like this. The other one is Illuvian by Alimera, Reticet by DME. I've never used these three, so I don't have experience with it. So finally, I want to deal with this question of switch and not switch. Right? I'm not as smart as William Shakespeare, but we can use basic principles to guide us. Number one, give anti-VEGF a proper chance to work. By that, we mean 6 months at least. Okay? Even longer. I think Professor Bressler would say a year, 9 months, a year, or never. Then you add laser, right? At 6 months. I follow that. I only switch steroids only at the end of that. So you wait for laser to work another 3 months. And then I have a choice of switching anti-VEGF agent. Let's say the patient has been on Avastin. Maybe I want to switch to Eylea. So then that will be another 3 to 6 months after that. So I wouldn't switch immediately. Certainly not in the first 6 to 9 months. We're looking at a switch 9 months or beyond. Some people will wait even 2 years before they consider switching to steroids. Why? Because if you look at protocol I, this was those who had persistent edema at 6 months. The visual acuity did not suffer from persistent macular edema. And what happens after that is some of them had resolution of edema. Did Professor Bressler show you this? He did. Okay, so I won't go too long. 10% no longer taken at 1 year. By 2 years, 40% no longer taken. Meaning that if you treat them long enough, more and more of the macular edema will disappear. And all this time, their visual acuity did not suffer. That's the learning point from protocol I. Right? And therefore, DRCRNet does not recommend switching actually. They say that keep going with anti-VEGF, keep going. And most times you will have better results. Having said that, I understand your frustrations. I also sometimes have to explain to patients why we are persisting with an agent when we don't know when the end point is. I can't tell you, oh, maybe after 24 months then the edema will settle, right? This is from Professor Bressler. He says, 60% of the 40% did not gain 10 or more letters. Would we have achieved more with switching at 6 months? Firstly, we don't know that if you switch, your vision will improve. In fact, most times they don't improve. Do you know that the other 40% with no switching could have gained switching? That's true, you don't know. Do you know that 50% will have IOP problems if you switch to steroids? Yes. Maybe 50% is a bit high with triamcinolone, but with DEX it will be 30%, probably. Do you know that if phakic patients develop cataract and there's persistent edema, 30% will not improve with cataract surgery? That one we know. So cataract surgery is not without its risk, right? Therefore, pseudo-phakic patients, go ahead. I think you can switch earlier if you want. Phakic patients, not so comfortable with that. And at the end of the day, 15-letter gain in those with persistent edema, no switching, was still quite respectable. So that's on the one hand, right? Those who do not switch, they don't recommend switching. On the other hand, the other side of the coin is that there are some specialists who now think that there may be early predictors of response. Okay, so there was a trial which is an analysis of protocol I. So using the same data from protocol I, this is by Praveen Dugal's group, that looked at 5-letter improvement, 5 to 9, and more than 10-letter improvement in the first 3 months of initiation of therapy. So this is after loading dose. And you find that, interestingly, those who gain 15 letters after 3 injections continue to keep the visual acuity at that range over the period of 52 months, meaning that they continue to swim in their lanes. They don't cross lanes. Similarly, those who didn't improve or hardly improve did poorly. Those with less than 5-letter gain after 3 injections continued to show very limited improvement. after 3 years. Similarly, when you look at CRT, central retinal thickness reduction, those who had very good change, more than 20% in the orange, had good visual acuity gains. Those who had less than 20% proportionate change didn't improve so much. In other words, if you look at their response at month 3, maybe you can predict that at month 12 they will stay like that. This is different from what ERCRNet is proposing, where if you keep going for 1 year, you get more and more gainers. After 2 years, there will be more and more gainers. In this analysis, their conclusion was that the early response was predictive of your final result at month 12. Okay? What are they saying? That is, this is just area on the curve. It tells you that over the entire period, the patients who did very well stayed very well. Their argument is that after 3 months, if you don't get a good response, switch. So this is quite different, right, from the DRCRNet approach. I don't use both to the extreme. I think 3 months is too early to pass judgment. And this is an analysis, so this is slightly different from a pre-specified outcome. So sometimes you have to take that with a bit of a pinch of salt. So generally, I don't switch at 3 months. I will switch after the 6 months, generally 9 months onward. Okay, and maybe you have your own criteria. And the last bit is about patients who might be unsuitable for anti-VEGF. I mean, the clear ones will perhaps be pregnant women, patients who had frequent injections, they cannot take it anymore, patients who are vitrectomized. Now, we don't know whether or not the duration of drug is significantly reduced after you remove vitreous. And then finally, recent cardiovascular events. Again, this is quite contentious. There is a lot of evidence that shows safety, right? Yesterday we talked about safety with recent MI and recent stroke. But in diabetics, that problem perhaps is magnified. Right? So in diabetics, I'm a little bit more cautious. If they've had a recent vascular event, then I'm more likely to use an anti-VEGF agent because there is an alternative. I mean, to use a non-anti-VEGF because there is an alternative. But if you look at data, actually the pool analysis do not show increased risk of the anti-VEGF agents in diabetic patients. So that's reassuring, right? It's not wrong for you to recommend using an anti-VEGF agent immediately after a stroke or an MI. I think it's more personal, maybe caution would be a good word to use. Because you look at overall risk, it was not increased. There is no evidence in the data that suggests that risks are increased. This is for protocol T, also no increased risk in agents. But the reality is that many patients have many morbidities, right, in diabetes especially. They have so many appointments, they have so many other things going on, that it's very, very difficult for them to meet the frequent injections. Let's say for 6 months, they have to come every month. And subsequently in the second half of the year, probably almost every month. Right? So maybe the practical may outweigh the theoretical advantages of anti-VEGF. So at the end of the day, you have a choice when to switch and what to switch to. If I switch, I will be switching to a DEX implant because I feel the DEX implant is safer than trying Sinodal, but it's more expensive. This is a 60-year-old male, 612 vision, 621 after 1 aflibercept. You can see the edema worsening. After 2 aflibercept, vision is maintained, but no improvement. I add macular laser together with the 3rd aflibercept. It settles slightly, visual acuity improves, 6/9. But subsequently, this visual acuity gets worse, recurs, and I decide to switch. He's pseudophakic, by the way. 6/12, 1 week after DEX, you can see a marked improvement of macular edema. After 2 months, it's completely dry. IOP is still good. 4 months, as I said, is about the limit. Edema recurs. Second DEX implant goes in. 2 months after that, 6/9 vision. 4 months, almost clockwork, edema starts to come back. So third implant, again good response, and then stable DR. This time it lasts for 8 months, not 4, for some reason. At 8 months he recurs, I give him a 4th DEX. Then the next one is 12 months later. Interesting, right? So this is a slow, inconsistent response, if you want to call it, to DEX. So he's now at 12 months out. So far, no further treatment, right? So this is quite a nice illustration of how maybe you can use the two together. So my first line is still anti-VEGF. I use it for 6 months at least. Add laser if it's not working. And at 9 months to 12 months, decide whether or not there's a case to switch to dexamethasone implant. I will do so if they are pseudophakic. If they are non-pseudophakic, I would be more cautious. But in general, diabetic macular edema outcomes have improved drastically over the past few decades. Right? We now have 3 anti-VEGF agents. We now have 3 steroids. Actually, we have more than that, but in Singapore, we only have the DEX implant and triamcinolone injections. Right? So I think, in summary, we need to consider carefully the response. If there's no response despite appropriate anti-VEGF, use laser first. That can reduce your risk of recurrences, and don't switch too early, because when you switch too early, you don't know whether or not you're given the anti-VEGF agent a chance to work. And if you do want to switch, at the moment, my preferred choice is the DEX implant. Okay. Thank you very much. Okay. I'll invite Dr. Takahashi up. Okay. Any burning questions? If not, thank you very much. I'm going to invite Professor Takahashi to give the last 2 lectures for today.